Hello and welcome. I'm Dr. George Lundberg, Editor-at-Large for MedPage Today. And we are in Chicago at the annual meeting of the American Medical Association, having conversations with a variety of medical leaders. And now we're going to talk with Dr. John Armstrong. Welcome.
Thank you very much, George. It's great to be here.
And thank you very much for being with us. We appreciate you taking time out of your very busy schedule here at the AMA. Dr. Armstrong is a faculty member in surgery at the University of Florida in Gainesville. He was at Miami before that. I don't know how you go with the Gators and the Hurricanes and stuff like that, but you've had an interesting career. You've lived in a lot of places. You've gone to college in a lot of different places and had residency time in the military, and then you became a young physician member of the Board of Trustees of the AMA. How's your career been so far?
My career has been fascinating. I've been privileged to really understand patients across the country. I've been privileged to have a variety of leadership roles within uniform medicine and now within civilian medicine. And I'm privileged to be the trauma medical director now for our hospital trauma system. We are the third largest trauma center in the state of Florida at this point, and we've only been in existence for 5 years.
Well, congratulations on that achievement as well.
Thank you.
You are today officially speaking for the American College of Surgeons, and tell me how the college feels about the healthcare legislation that came in this year and what's going to happen with it.
Well, the American College of Surgeons believes strongly that we need to promote access to quality care for the patients of America. And so that's going to involve creating processes where we actually have quality, safe care, having a workforce that our patients can access that care through, and further addressing the liability issues that continue to really cause ripple effects in delivery of care. The fourth element of this is reducing the cost of health care.
Well, obviously, we all want to change that liability problem in some kind of way. Fortunately, there are at least pilot programs in the legislation that was passed, with the idea that out of pilot programs, we might be able to figure out the right thing to do, because frankly, I've been watching the medical liability issue all my professional life, and that's a long time, and I don't know what the right thing to do is. Does the college have a position as to what the right thing to do is?
Well, the American College of Surgeons does look at the evidence, and clearly when you look at the micro legislation and law in California, and you look at liability reform in Texas, it is apparent that when you cap non-economic damages, you do see a stabilization of premiums as a way of reducing health care costs.
Yes, you see a stabilization of premiums, there's no question about it. MICRA has been successful in my point of view, and I'm licensed in the state of California, and a good friend of mine wrote the MICRA legislation originally. However, I don't think that kind of change alters defensive medicine, which has now become incorporated into practice standards, thinking processes, how everybody actually behaves. And I don't think the legislation to cap the premiums changes that behavior. Is there evidence that it does?
Well, I think defensive medicine is part of our culture now, and until there is a national conversation about this and true national liability reform, I suspect that you're right, that we will build these types of defensive measures into guidelines, and yet at the same time we must emphasize that our guidelines are about providing quality, safe patient care, and we work very hard to make sure that they adhere to the best evidence.
So what is the college position on saying, hey, I'm sorry I operated on the wrong side of your brain?
Well, the college at this point does not have a particular position on that. The college does believe strongly in open conversations with patients and encourages strong communication. In fact, the college has a course about how to communicate better with patients so that patients understand what will happen to them through informed consent, and further that there can be the conversation when things don't go as planned.
When I talked to Tom Russell when he was the CEO of the American College of Surgeons a while back, and he did some video with me in my prior work, we talked about transparency, and we also talked about surgeons keeping logs in their offices about what outcome happened when they operated on somebody, he told me, and I was amazed that that hadn't been routine by surgery in the United States outside of medical centers. And he said that was being established. Do you happen to know how that's going?
It's actually going very well. It's called American College of Surgeons Case Log. It is a computerized database that allows you to enter the patients along with the indications for operation, the operations themselves, and the outcomes associated with that. This is kept in a protected account so that you can actually establish benchmarks for performance. And that has proven to be very useful. And really a follow-on to that is the National Surgery Quality Improvement Program of the American College of Surgeons, which is really, it's doing the same sort of thing within hospitals.
Okay, I'm very happy to hear that. Outcomes at 1 month, outcomes at 1 year, or an open-ended outcome file?
In terms of the NSQIP?
Yeah.
It is outcomes at 30 days.
At 30 days.
Correct.
Okay, but not did this cancer come back in 6 months or something like that. So we're not to that point.
We're not to that point yet, but this is a great start. And what this program involves is using actual clinical data, not administrative claims data, but clinical data that has a variety of defined endpoints where we can actually measure our outcomes. We can establish benchmarks, and we provide to hospitals their observed to expected ratio relative to these benchmarks. So the hospitals can immediately see how they are doing relative to other hospitals of their same type, and can thus initiate performance improvement programs.
Well, then let me congratulate you, congratulate the American College of Surgeons, and congratulate everybody who's participating in this process of measuring how things work, because Dennis O'Leary always used to say, you manage what you measure. Thank you for being here with us today, and thank you for watching us and listening to us. Dr. John Armstrong from the University of Florida in Gainesville has been with us, representing the American College of Surgeons, and I would say representing them very well today. So,
well, I thank you very much.
Thank you very
it's
much
a great
for being with us. And remember, you can make comments after you've listened to this and decided what you think about what we've been saying, and put those on the comments board. I'm Dr. George Lundberg, Editor-at-Large for MedPage Today.